Now, way back at the end of the 1950s, surgeons in Canada performed this country's first successful kidney transplants, first in Montreal, then right here in Saskatoon. And we have come such a long way since then. The incisions today are smaller, the tools are more precise, and surgeons like Dr. Mike Moser are a big reason why kidney patients get a new shot at life.
The thing that drew me to surgery in the first place was making these little connections there. Anastomosis is what we call it. And I think there's a lot of parallels between HPB surgery and transplant surgery because we're making those little tiny connections there. I love making those little elegant, tiny connections.
Dr. Mike Moser is our guest today on Researchers Under the Scope. Hello, I'm your host, Jen Cannell, and it's Wednesday. It's the 19th of June, 2024. Now, we are on the first floor of the engineering building at the University of Saskatchewan today, and our guest is Dr. Mike Moser. He's a professor of general surgery at the College of Medicine, and he specializes in something called HPB, Hepato-pancreato-biliary surgery. I can totally see why they use the letters HPB. And Mike Moser, he's one of the reasons we expanded using something called a NanoKnife across so many areas in medicine. Thank you for being our guest today, Mike. Welcome to Researchers Under the Scope.
That's great to be here. Thank you for having me.
When we walked in, you showed me the NanoKnife. And it's sort of like, if you've ever been to a restaurant where they have like a robot waiter, it kind of reminded me of the robot waiter. Like, slides around, it's on wheels, and then it boots up, and then it starts to get serious. But you first used the machine that's here back in 2015?
That's right. I remember the day we were in an operating room at St. Paul's Hospital in October, and it was to treat a tumor that there was no surgery for. There was no other options for this patient. Chemotherapy is an option, but we know that's not going to cure a tumor, generally, the kinds of tumors that we work with. And so for a lot of these patients, the only option left is something like the NanoKnife for these tumors that can't be removed with surgery. And we proceeded very carefully, very cautiously. It took way longer than it takes nowadays, but in the end, everything worked out well.
And when you actually go in with the NanoKnife, what is happening? Like it makes sort of a funny little like a weird little suction sound. You actually have a little video of it.
Sure. Yeah, well, nobody knows what makes that sound, but we were really kind of enthralled by the concept when we first heard about it, because it's a technology for destroying tumors, for ablation, as we call it, that doesn't use heat and it doesn't use radiation or anything. And they said because of that, it's safe to use nearby very delicate structures like bile ducts or pancreatic ducts or bowel or really thin-walled veins, that sort of thing. And so we were very much intrigued by that. And the more we learned about it, the more we came to find out that this was technology that produced a very high current, like we're talking 2,000 volts. Doesn't mean a lot to me. Somebody said it's kind of like those big plugs on the dryer. You take like 10 of those. That's about 2,000 volts, although a physicist might argue that's not quite right. It's a lot of juice, for sure. But the catch is that the current is delivered for an incredibly tiny amount of time. I have a hard time wrapping my head around how we can deliver a current for such a brief period of time, but this is the period of time, 70 millionths of a second. It's extreme. It's like, why bother? It's such a short period of time. And yet that combination of the high current and the very, very short duration, what that does at the microscopic level is it's firing billions and trillions of little tiny holes into all the cells between two electrodes, because of course a current has to pass between one electrode to another. And these little holes, they cause those cells to become like leaky ships or leaky submarines, somebody said. And so they start losing their contents, they're losing their proteins and electrolytes, they're taking on water, and the cell, believe it or not, has little tiny pumps, and they start to pump to try and get things back to equilibrium. The trouble is they can't keep up. I mean, this is a battleship that's got a lot of holes in it. Eventually, the pumps deplete all the energy from the cell, and the cells die. And so you have this sort of a very gradual cell death without using heat, without using radiation, and the cells in that treatment zone generally die within about the next 4 hours.
Oh, wow. So you can actually see results starting to happen fairly soon.
It's pretty quick. They've shown that, yeah.
Ooh. And if I take you back in time, like to how you even got on this path in the first place, did you always know that this is the direction you wanted to go?
Yeah, I think I took kind of a roundabout way in getting to this, but I'm glad I got to where I got, because this is, I mean, it's a very serious topic, serious diseases we're treating, but at the same time, we're having a lot of fun. We're meeting a lot of great people, doing a lot of great collaborative work. But to be honest, when I was a little kid, I was very much a numbers guy.
Oh, like math and stats, probability maybe?
I was all about solving complex puzzles and math problems and equations and that sort of thing. I really loved that. I guess it was the appeal of being challenged by a tough question. But as I got older, I started to listen a bit more to my grandmother's stories. And my grandmother, she had been a nurse right around the time of the first antibiotics and the first x-rays, and I loved her stories. It was a fascinating time to be in healthcare, pretty primitive by today's standards, but she had a very fulfilling career. She told these great stories. And by the time I was in high school, I thought that would be a great way to solve a lot of problems. To use science, to use math, would be to go into medicine. And so I wound up applying for and getting into medical school. And when I got into medical school, I think really I wanted to be a diabetologist. I wanted to be somebody who could help all these people, and there's millions of them, with diabetes and all the problems that come with diabetes and that.
Was that just because it's so widespread and there would be so much you could actually make a difference with, or?
It was, and I heard about it in the family tree, and you know, I think some people will ask me, did you always want to be a surgeon? Because there are a lot of people who get into med school and they say, you know, I've wanted to be a surgeon since I was 8 years old. I don't know how they knew that, but I was kind of the opposite. I think probably when I got into med school, the last thing in the world I wanted to be was a surgeon, because I couldn't stand the sight of blood. I really still can't stand the sight of blood. And, you know, those dissection labs in undergrad where you're dissecting a dead frog or a dead fish or what have you.
I tried to avoid those at all costs. I hated them.
Oh, yeah, me too. I really did not like the smells and the sights and the textures and all that. I really didn't like. So surgery was the farthest thing on my mind.
Yeah, but what happened?
Yeah, that's a good question. Well, over my years of medical education, I've been really lucky to have had a lot of great teachers and a lot of great mentors. And one in particular, I think, was probably the reason I became a surgeon, Dr. Garth Warnock. And he's one of these guys. He was a diabetes fighter. He did research in diabetes, in islet cell transplants to try to cure diabetes. And he was also this guy who looked like he was always having a good time with his job, you know, very charismatic, very enthusiastic, very great teacher. And, you know, so much so, and you know, his attitude towards diabetes matched mine. I decided I'd do a summer research project with him. Awesome. And he was kind of unique in that he was a clinician and a researcher. And so 2 days a week, he'd go across the street pretty much to an actual lab with all the stuff you'd see in a lab, and do some really good high-level research there 2 days a week. And so I admired him for that too. And it was a great summer project. And one morning he comes to the lab and he says, Mike, today we're going to do something a bit different. You're going to come with me to the operating room. And probably a lot of medical students would have been thrilled with that, but I was pretty terrified. I wondered if I might throw up or pass out or both. But, you know, he seemed so excited about it. He seemed to think this would be a really good thing. And I really had a hard time saying no. So I wound up in the operating room that day.
What do you remember about that day?
I remember the walk over and just being terrified. What am I going to do? I didn't bring a change of clothes if something happens. But I walked into the room, And it wasn't at all what I expected it to be. It was this very controlled, very neat and tidy and organized and monitored place where everybody was working together. The patient was already asleep. The only part of them you could see, everything else was covered up, was draped with sterile drapes. But the only part you could see was the abdomen, the part we were going to focus on. And the surgery that Dr. Warnock did that day was easily the most amazing thing I'd seen in my medical training up to that point. He was making a connection of a little bile duct, and it's probably, 6 millimeters in diameter, connecting that one stitch at a time to an area of intestine to get around a blockage in that bile duct. And I thought that was beautiful. I thought that was amazing, way different than the cadaver lab. This was living anatomy. Everything was pink and healthy, and he just made it look so beautiful. And I think at that very moment, that very day, I think I decided not only, wow, I have to become a surgeon, but I also decided I want to do that operation someday. And from there, I didn't change my mind. That was really a major turning point, that one day that Dr. Warnock kind of forced me to come to the operating room.
And you didn't throw up?
No, that was the thing. I played some sports growing up, and they talk about a lot of analogies between sports and surgery. I think that's pretty accurate. You've got the teamwork and all that, but you've also got getting into the zone, that focus that athletes talk about. I think it's absolutely true too for surgeons. I walk into the operating room. I think for many of my colleagues, they walk into the operating room, you get into this zone and you become so focused on fixing the problem or stopping the bleeding or taking that tumor out. You're so focused on that I didn't notice the blood anymore. Didn't bother me, and hasn't bothered me since.
Well, yeah, and sort of building on that and on the research side of what you do, how do you decide what you're going to pursue?
Definitely, I think that's one of the advantages of being a clinician and a researcher is that as a clinician, we're going to encounter situations in our everyday practice, some of them really big questions, some of them really small questions, and questions nonetheless that we'll be able to say, there's research that needs to be done on this or that or the other thing. And my two sort of main areas of research interest can be described, I think, as two opposing poles. One of them is destroying cells and tissues, and the other one is actually protecting or preserving tissues and cells. In the case of destroying cells, well, it's like the NanoKnife that we talked about, finding better ways to kill cancer cells with technology, with the sort of the engineering bent. We're also collaborating now with the Department of Chemistry and Immunology and Pharmacology and all these other groups. Been some great collaborations going on.
Organ transplants are also a place where you shine. And how did that come to be?
My interest in transplant, I think, dates back a long time. And I think the thing that drew me to surgery in the first place was making these little connections there. Anastomosis is what we call it. And I think there's a lot of parallels between HPB surgery and transplant surgery because we're making those little tiny connections there. I love making those little elegant, tiny connections. With a transplant, we're generally connecting up an artery and a vein from the donor organ to the recipient, and then some other tube. In the case of a kidney transplant, it's connecting the ureter of the new kidney to the recipient's bladder, that sort of thing. So that's the thing that the two fields have in common.
But it's not Scotch tape that you're using.
No, it's some fine little sutures. Somebody said they're finer than a human hair. I guess the question is whose hair, but really, really fine sutures that are really very sturdy. We're making tiny little connections. A lot of times, just one stitch at a time. Sometimes with magnification, sometimes not.
And trying so hard to preserve that tissue and make sure that nothing gets damaged in the process.
That's right. So that's my other area is with transplantation. You can well imagine that if you take an organ out of one person, then you flush the blood out, you cool it down to 4 degrees, which is a common way of preserving organs, and you have it outside of the body with no blood flow for a few hours to 24 or even 30 hours, there's going to be some injury that's going to happen. That's going to be stressful to the cells within that organ. And then you take it and you put it inside somebody new. Their immune system's going to try to attack it. It's going to warm up. It's going to go from 4 degrees to 37 degrees very, very quickly. All those things are stresses. All of those elements are ways that the kidney or whatever organ is going to lose some cells. We know we're going to lose some function going from person A to person B. So it's funny how some ideas come at 3 o'clock in the morning because for a transplant surgeon, we know that's our time to shine. That's a time when we're working. That's usually when we're working. It's after midnight, that sort of thing. So some funny ideas come to mind at 3 a.m. And I remember a number of years ago looking at the fluid that we use to preserve the kidney. And the kidney's either just floating in this fluid, it's had it injected to kind of flush the blood out of the arteries and veins. Other times we can put it on a pump that keeps this fluid circulating. And once we start sewing the new kidney into the new recipient, well, at that point we can discard that preservation solution. But the question that came up at 3 o'clock in the morning was, hey, I bet you there's some pretty useful information in that fluid. Is there some way we could take that fluid? And that was no problem because it's fluid that we're going to throw away anyway. And so over the next few years, we collected hundreds of samples of this fluid and looked at it in a lab, a pharmacology lab, and found some very useful insights into what's happening while the kidney's being preserved. And that actually gave us some drug targets, some proteins that we could target to be able to reduce the amount of injury that happens to a transplanted organ.
Which are the proteins that you have to target?
Yeah, we identified probably 10 different proteins. And one of them was these matrix metalloproteinases. And they're kind of interesting because they can be blocked by a fairly common antibiotic that's really not used very much anymore. So, we went on to show that at least in the lab setting that could reduce the amount of injury that's happening to the kidney. But there's these 10 other targets that one could look at in a similar fashion to try and reduce the amount of injury that happens.
Sort of just by looking at, well, this is going to go to waste anyway, but it's got direct contact with what I'm interested in. Let's see what it can tell us.
Yeah, the kinds of ideas that'll come up at 3 o'clock in the morning.
Oh, what else has occurred to you at 3 o'clock in the morning?
I guess some other projects just arise from everyday settings in clinical life. For instance, one time we had a patient who had a complication after a needle kidney biopsy. Not a big procedure, but when we looked at the results, there were more complications than we like to see. And so given that there are so many kidney biopsies done, we were able to look at hundreds of kidney biopsies and look at technical factors and institutional factors and all these sorts of things and identify factors that would sort of be associated with a higher risk of developing complications from a kidney biopsy. And we were very happy that the health region took an interest in that sort of work, and they were able to put some teeth behind us and these recommendations we came up with to try to make kidney biopsies safer. Just last summer, a medical student looked at, again, hundreds of kidney biopsies done before the recommendations of 2017, and then about 5 years of kidney biopsies after the recommendations. And, we were thrilled to see that these recommendations had made a difference. So there was about a 60% reduction in the amount of complications as a result of a few recommendations. And
that's enormously significant.
That was a good feeling to see that it had made that kind of a difference.
So these days, what are the research questions you're contemplating?
Well, I think we continue to do a lot of work around the NanoKnife and ways of maximizing irreversible electroporation. I guess that's the more generic term for the NanoKnife. Ways of combining it with chemical means to make it more effective, ways of getting the immune system on board with us, ways of adjusting the settings, because that's what they do so well here in engineering. They're looking to optimize settings. And when we got the machine, there's one setting. There's not too much you can manipulate, so it made sense that we should look for different ways to adjust the settings. Probably the thing that excites me the most right now is this combination of NanoKnife with immunotherapy, with drugs that can kind of boost the immune system. They're actual drugs that are being used as part of cancer therapy because, of course, the immune system is a part of our body's defenses against cancer.
Yeah, you really want the immune system on board.
That's right. That's right. And if we could somehow get it even more on board, that would be wonderful. But I guess without getting too far ahead of ourselves, I gave a talk in 2014 when I was trying to rally support for getting the NanoKnife here in Saskatchewan. And after that presentation, a well-renowned researcher came up to talk to me. And he had heard, of course, that the NanoKnife is able to kill cells without heat and without radiation, that it kills cells by punching millions of holes into the cell. And his hypothesis was, you know what, I betcha the proteins, the markers on the surface of those cells that you kill with the NanoKnife, I betcha those proteins are still intact. They haven't melted, they haven't become denatured by the heat or anything because there's no heat.
Right.
He said, you know, this kind of reminds me of something. The very early vaccines, and this is not really the way they make vaccines anymore by any stretch, but the very early vaccines, what they did was they took the actual disease-causing organism and they kind of killed it without affecting the proteins on the surface. And that way you could expose a patient, a person, to this protein, but they wouldn't get sick because all the cells were dead.
To inoculate them, yeah.
That's right. That's right. And then the immune system could get to know those proteins as something that's foreign and kind of rally the troops so that if they ever see that protein again, they're going to unleash a really big battle to destroy it. So later on, if one's exposed to the actual pathogen, or
if that tumor grows back.
That's right.
Or sets up shop somewhere.
Exactly. Exactly. So in a sense, he said, well, this could be like a killed cell vaccine situation because we've got these dead, helpless cancer cells. They're still exposing their proteins. They're still showing their proteins to the immune system. And then this way, we can teach the immune system to focus in on these proteins. And then let's say there's cancer cells elsewhere in the body. They'll be able to clear those out. If it comes back, they'll be able to take care of those. And he went back to the lab, did a few experiments, and within less than a year, he said, yeah, you know what? That's absolutely right. That's what happens after a NanoKnife treatment. And he even went farther than that, and that's where the immune boosting part, the combination treatment comes in. He added in the immunotherapy drugs that are available. And these are some of the results that probably excite me the most of anything I've ever seen in a lab. Basically, it's a tumor model where there's two kind of identical tumors that are made to form. The immunotherapy drugs are given. The NanoKnife, or its equivalent in the lab, was administered to one of the two tumors. And as expected, the tumor that's treated with a NanoKnife, it dies. Within a couple of weeks, it pretty much disappears, leaves a little scar. But the exciting part of all this is that the tumor on the other side also disappeared. And you got to remember, that tumor was not treated by the NanoKnife.
It was not touched by it.
Wasn't touched by it. And so that was proof that this was the immune system going to attack this type of cell anywhere in the body. And so very, very, very exciting results. They published that in a very, very high-profile journal. Other labs have confirmed those results, and there's some clinical trials on. But this is extremely exciting because a lot of patients that we see with these cancers in HPB surgery, they present when they're very advanced. In other words, they're metastatic. So they've gone elsewhere to the liver or to the lungs, those sorts of locations. And I think there's this great potential, and I hope it comes true someday, that one may be able to give these immune-stimulating drugs, these immunomodulators, and then treat any one of the spots of spread of the tumor, something that's easy to get to, easier to get to than the pancreas anyway, which is kind of tricky, and have the tumors everywhere in the body disappear as a result of that because, again, the immune system is learning about these proteins. It will eventually unleash Armageddon on any cells that express those types of proteins anywhere in the body, including the primary tumor. So that's really kind of neat that one could actually treat the area where the tumor started without directly treating it, if that makes sense.
And
Yeah,
it wouldn't just be pancreatic cancer.
That's right. That's right. The nice thing about the NanoKnife is it's able to be used. You could use it pretty much anywhere in the body. The reason it's safe to use in the pancreas, it's safe to those nearby structures. That applies to any part of the body.
Brains too.
Potentially for brains. And we had a graduate student recently who did work on brain cancers in an in vitro type of model. But it does look promising there. And it makes sense to use this in something as sensitive as the brain, where you've got all those vessels and some very sensitive areas, to be able to treat the cells without affecting all that network of blood supply. I think some of the biggest ahas and the biggest epiphanies come when you bring together two different fields. And there's always that time when you have to kind of bring everybody to speed with where they're coming from their two different areas or three different areas. But once you're there, it's amazing how the ideas start to fly. And really, really do enjoy the collaborative work. And it's something that I think we do very well here at the U of S.
Yeah. Well, I'm so glad you're here, Mike. Thank you so much for being a guest with us here on Researchers Under the Scope.
Well, thank you very much for having me. Had a lot of fun today.
Dr. Mike Moser is a professor of general surgery at the University of Saskatchewan's College of Medicine. He specializes in HPB, and he is one of this province's top transplant surgeons. Right now, his research looks at ways to use NanoKnife technology to make surgeries safer and less invasive, and to see where else we can apply NanoKnife technology to really tricky cancers. To find out more, look for Mike Moser at medicine.usask.ca. Researchers Under the Scope is a presentation of the Office of the Vice Dean of Research at the U of S College of Medicine. We record and produce this podcast on Treaty 6 territory, and that means we pay our respect to the First Nations and Métis ancestors of this place. We reaffirm our relationship with one another, and we'd sure like to thank you for sharing your ears with us and tuning in. I'm your host, Jen Cannell, and I think this is your periodic reminder to talk to your family about transplants, about organ donation. Yes, it really does make a difference. And if you like staying up to speed on what the latest is in terms of biomedical research at the U of S, find those three little dots up in the corner of your podcast player, hit follow show, and that way you'll have all the latest episodes of Researchers Under the Scope.